To begin today's presentation. Please note that you can submit a question for Dr. Nelson at any time during the presentation by typing it in the toolbar on the right-hand side of your screen. We will answer questions when Dr. Nelson has completed her presentation. Due to the large number of attendees tonight, we may not be able to get to all questions, but we will answer as many as we can. It is my pleasure to introduce to you Dr. Mary Elizabeth Nelson, a nurse practitioner at the Medical College of Wisconsin, who specializes in spasticity management. Dr. Nelson, I will let you begin.
Well, thank you, Laura, and thank you to everybody who's tuned in today. Today I want to give you a general overview of spasticity and to talk about what spasticity is and some of the treatment options to people living with spasticity. Whether you are listening in for yourself or for someone that you care for, hopefully today's information can help you optimize your spasticity treatment options. Next slide, please. So, what is spasticity and who does it affect? Next slide. Spasticity is a broad description of a primary symptom of damage to the central nervous system.
Dr. Nelson, we are having trouble with the slide deck here.
Okay.
Stop you for a minute. I'm having trouble advancing the slides. Okay, just one moment. Sorry for the technical difficulties. Okay, so I'm on the Your Speaker slide.
Oh, okay. Why don't we move forward?
Can we back up here a little, move forward one, today's agenda?
Sure. Should I start over?
Nope, this is fine. We'll start on the agenda. Sorry, everybody.
Okay. So we've already gone over today's agenda to speak of a general overview of spasticity, what spasticity is, and some of the treatment options available to people living with spasticity. So we'll move forward to the next slide of what is spasticity.
Okay.
Great. All right. Thank you for your patience, everyone. I know it can be a little confusing with today's technology. So, what is spasticity and who does it affect? Next slide, please, Laura.
Okay.
Oh, okay. Spasticity is a broad description of a primary symptom of damage to the central nervous system. It is caused by damage to a part of the brain or spinal cord which controls voluntary movements. It is most commonly seen in patients with spinal cord injury, multiple sclerosis, cerebral palsy, stroke, or brain injury. Spasticity can look different from person to person, but often results in tight, stiff muscles that make movement difficult or even uncontrollable. Next slide, please, Laura.
Okay.
Spasticity has many symptoms. Primary symptoms can include tight muscles or increased muscle tone and overactive reflexes. Involuntary movements such as active spasms or fast involuntary muscle contractures known as clonus can also occur. Additionally, muscle spasms can result in muscle pain as well as decreased ability to perform functional tasks or delayed motor development. Next slide.
Okay.
As a result of spasticity, a number of complications can arise. Difficulty performing personal care such as dressing and hygiene can occur. Abnormal posturing, making sitting, standing, or walking difficult, or in extreme cases, positioning in bed is often seen. Additionally, contractures or permanent shortening and tightening of muscles and tendons may occur, or even bone and joint deformities can be found. Next slide, please.
Okay.
Unfortunately, spasticity is very common. Many research studies have been performed to determine spasticity's impact on different patient populations. It is estimated that spasticity affects more than 12 million people worldwide. As I already mentioned, spasticity affects patients with spinal cord injury, multiple sclerosis, cerebral palsy, stroke, and brain injury. It has been found to be the second most problematic symptom in spinal cord injury patients, affecting more than 40%. 84% of patients with multiple sclerosis have been found to have spasticity. 80% of patients with cerebral palsy have been found to have spasticity. 38% of stroke patients, just 1 year after their first stroke, have been found to have spasticity. And 53% of patients with brain injury occurring in the midbrain have been found in some of the studies as we have listed here on the slide. Next slide.
Okay.
As I've already discussed, spasticity can manifest in many ways. It may limit movement in arms or legs, affect the ability to walk, limit movement which can impact dressing, bathing, or eating, and affect not only the person with spasticity but also their caregivers. Spasticity can lead to pain, and as a result, it can lead to deformities of joints such as contractures or lead to skin sores. So, what can we do about treating spasticity? Next slide.
Okay.
Well, spasticity can be treated, and I can't emphasize that enough. No one treatment is right for everyone, but I believe it is important to know what treatment options may benefit you. Next slide.
Okay.
First of all, I want to emphasize there is hope for those living with spasticity. Spasticity treatment is simply symptom management, and although there is no cure for spasticity, controlling spasticity can result in an improved quality of life and achievement of function, and both the function and the comfort goals that any individual might have. Next slide. There are many approaches to spasticity management, and often a combination of treatments may be required to adequately or optimally treat an individual patient. Treatment options include many of the following, including oral medications, rehabilitation therapy, managing spasticity-related pain, intrathecal baclofen therapy, motor point blocks, nerve injections or other injectables, neurosurgery, as well as orthopedic surgery. So let's review some of these more in depth to give you more information. Next slide.
Okay.
Rehabilitation therapy is a very common treatment for spasticity and can be performed in a number of settings, including an acute inpatient unit, the outpatient clinic, and for some patients who qualify, even at home. Rehabilitation therapy may include physical therapy, occupational therapy, and speech therapy. Goals of rehabilitation therapy may include optimization of function, stretching of tight muscles, and the retraining of spastic muscle groups. Next slide.
Okay.
For many patients, oral medications may be utilized. There are different classes of medications to treat spasticity, and each works very differently to reduce spasticity's effect on the muscles and the nervous system. Some medications work directly on the central nervous system, such as baclofen and Valium. Some work directly on the muscles, such as Dantrium, and other medications work on spinal receptors to reduce spasticity, such as tizanidine. In many cases, a combination of oral medications best controls spasticity, and no one combination is going to be right for any one patient, so working closely with your medical provider is important to find the right combination for you. Next slide.
Okay.
Unfortunately, in some patients, oral medications either cannot adequately control spasticity or may cause unacceptable side effects. So in those cases, there are additional treatment options, which we'll discuss now. Next slide.
Okay.
Injection therapies are an effective treatment option for some patients. Most often, injections are targeted at specific groups of muscles, controlling a focal area of the body, such as one arm. Injectables such as botulinum toxins or phenol tend to block communication between the nerve endings and the muscle groups. The medication is injected directly into the problematic area to reduce spasticity. Injection therapy does wear off over time and requires repeat injections over time to be effective. Next slide. Okay. Selective dorsal rhizotomy is a surgical option for some patients. In a selective dorsal rhizotomy, a surgeon dissects or uncovers small nerve rootlets in the spinal cord and cuts certain sensory roots that cause muscles to contract and spasm. This treatment is not reversible and most often is used to treat only lower extremity spasticity. Often, intensive physical therapy is required after selective dorsal rhizotomy to receive the optimal benefits. Next slide.
Okay.
Orthopedic surgeries are a more common procedure for patients with spasticity. Orthopedic surgery targets muscles, tendons, or bones to reduce spasticity or release the tightness causing the deformities in spastic limbs or in the spine. Orthopedic surgery can include tendon or muscle lengthening or releases, tendon transfers, as well as osteotomies and bony fusions to correct deformities that are caused by spasticity. Next slide.
Okay.
Another treatment option is intrathecal therapy. Intrathecal therapy is the delivery of a liquid form of medication directly to the spinal cord. Intrathecal therapy requires less medication than oral, as it is delivered right to the site of action, which is in the spinal cord, and does not have to circulate in the body. This often minimizes the side effects for some people because some people with oral medications can experience side effects from the blood levels of medication circulating throughout the body. Next slide.
Okay.
Medtronic ITB therapy is intrathecal baclofen therapy. Medtronic ITB therapy uses a liquid form of baclofen, which is delivered via surgically implanted programmable drug pump and catheter directly to the spinal cord, which is the site of action of the medication, and to the fluid surrounding it to reduce spasticity. Next slide.
Okay.
Medtronic ITB therapy is FDA approved for severe spasticity of both spinal origin and cerebral origin. This means that patients suffering from spinal cord injury, multiple sclerosis, cerebral palsy, stroke, and brain injury may be appropriate for this treatment option. In most cases, patients must fail oral baclofen, meaning that they do not respond to or cannot tolerate the side effects of oral baclofen before being a candidate for intrathecal baclofen therapy. Additionally, labeling approves patients 1 year after brain injury for consideration of intrathecal baclofen therapy. Next slide. In most cases, a screening test where a small dose of baclofen is injected into the spinal fluid will show if a patient is appropriate for Medtronic ITB therapy. However, in some situations, patients should not receive ITB therapy. These include if you have an infection, which is actively in your body at the time of consideration of the trial, if you are allergic to baclofen, or if your body size is too small to hold the implantable pump. Next slide. ITB therapy is not new. It was approved in 1992 for spinal origin spasticity and in 1996 for cerebral origin spasticity. To date, greater than 60,000 patients worldwide have been implanted with a Medtronic infusion pump. Next slide. ITB therapy requires an active relationship between the patient and the medical professional team. Dedication to regular appointments, medication refills, and communication regarding spasticity and its impact on your life is necessary to determine the right dose and optimize treatment if you receive ITB therapy. Next slide. Okay. Now this slide and the next slide include a lot of information, and we will be reviewing it again at the end of the talk. But there is important safety information to be aware of if considering ITB therapy, as a sudden stop of intrathecal baclofen therapy can result in serious illness or baclofen withdrawal symptoms. It is important for patients with a baclofen pump to keep all scheduled refill visits so they don't run out of medication or baclofen, and to understand the early symptoms of baclofen withdrawal. As a result, it is important to communicate fully with your healthcare provider before starting ITB therapy and to be educated on the risks as well as the signs and symptoms of baclofen overdose and withdrawal if considering ITB therapy. Next slide. For those of you who are tuning in online, the previous slide and this slide include important safety information. If you are considering ITB therapy, please discuss both the benefits as well as the risks of ITB therapy with your healthcare team to make an informed decision regarding if ITB therapy is right for you or for the person that you take care of. Next slide. For those of you online, this is a picture of Michelle, and she is a patient who has had a partial spinal cord injury and underwent pump placement in 2007. She has seen the benefits of ITB therapy and how it can impact her spasticity and her quality of life. And she says that if you are thinking that you may be experiencing spasticity, talk with your healthcare provider so treatment may begin as soon as possible. Next slide. We've briefly covered a lot of information in a very short period of time, and I want you to be aware that there are many additional resources to learn more about spasticity and the diseases and injuries that lead to spasticity. If you would like to know more information, some of the resources include the Brain Injury Association of America, MS World, National Stroke Association, United Cerebral Palsy, National Spinal Cord Injury Association, and the Christopher and Dana Reeves Foundation. Next slide. I want to thank all of you for your attention and time. Hopefully this information was helpful for you. I know it's very difficult to provide in-depth and meaningful information via this webcast, but hopefully some of the questions that have come in during the lecture. We'll answer some of the concerns that may be on your mind. So Laura, I'll now turn the next part of the presentation over to you in case we received any questions.
Yes, thank you, Dr. Mary Elizabeth. That was very informative and very helpful. We do have a few questions here, and we'll start with the top one here. How can you tell if oral baclofen is not working? How much oral baclofen can a person take?
That is actually a really excellent question, and for this question as well as all questions, I'm going to say please make sure that you don't only take my word for it, but that you speak in depth to your healthcare provider who's prescribing medications. But with that said, you know, oral baclofen is a little tricky. The drug references that we as healthcare providers use tell us that the maximum dose is around 60 milligrams a day. However, I will tell you in spasticity practice, where we work with this drug on a daily basis, the maximum dose is what you can tolerate. So this is a drug that is cleared through the kidneys, so as long as you have good kidney function, it depends on how you're tolerating the side effect profile. The side effect profile of oral baclofen includes dry mouth, constipation, fatigue, and weakness, and at really high doses can result in some generalized confusion. So if you are not having too much weakness, too much dry mouth, too much constipation or urinary retention, generally you can continue going up on the dose. Now, realistically, I've seen patients at doses well over 100 and even 200 milligrams a day, but I would generally advise, and what we do in my practice is, if you are taking oral baclofen 3 to 4 times a day and find that you need to escalate your dose, most likely this medication is not working for you, and it's time to look to combining with another oral treatment or adding on one of the other treatments we spoke about today.
Great. Is there a chance for overdosing or underdosing on a baclofen pump?
Another excellent question. Absolutely. Nothing in life is absolutely fail-safe. So there is always a chance of either overdosing or underdosing on a pump. Now, realistically, the device itself is incredibly safe. We manage well over 250 patients with intrathecal pumps, and we have actually only seen one overdose in the history of our program, and that was due to human error. The device itself cannot magically go out of control and provide too much medication. Only human error can do that. So that safety margin is pretty tight, and with a provider that's paying close attention, that risk is very low. Underdose or withdrawal is more likely to occur, although in the realm of things, still a very low occurrence rate. And that can happen should you miss your refill and allow the pump to run out of drug, or should there be a catastrophic failure of some component of the system. This likelihood is very small, and so what you want to do if you are considering ITB therapy or currently implanted with ITB therapy is to speak directly with your healthcare provider, make sure you're aware of the classic signs and symptoms of withdrawal, have an emergency treatment plan in place, including some oral medications, as well as knowing how to contact your healthcare team so that should you be suffering any of the signs and symptoms of withdrawal, you have an action plan in place to keep yourself safe and to adequately determine what has occurred so that it can be corrected.
Can Botox be used for spasticity in your legs? Is the next question.
I'm glad somebody asked that, because the way we presented the slides, it suggested that the injectables can only be used in one area of your body. The injectables are excellent treatments, but they only work where you put them. So we tend to describe them as a focal treatment. The question spoke to Botox, which is a brand name product. There's a number of brand name products under the botulinum toxins, and they all work along the same principle. But you can absolutely use the botulinum toxins as well as the other injectables such as phenol or alcohol in multiple different areas of the body, including the hand, the arm, the back, the neck, the leg, the foot. It's a matter of focusing it in the area that is most problematic for the patient.
Great. How long is oral baclofen given without success before it is considered failed therapy?
Wow, everybody is just right on the ball with these high-level questions. So oral baclofen, you know, it's going to depend on the individual, the other comorbidities that you are suffering, meaning the other kind of medical problems that you might be facing and might be impacting your spasticity. The general rule of thumb is if you have tried the medication, escalated the dose over time, meaning you're up to about 3 times a day and maybe taken it from the starting dose to doubling that dose, and it's been anywhere between 1 and 3 months and it's not effective for you, that is a failed therapy. This is not a medication you need to try 6 months or a year on to know it's not working. If you've been at a dose for longer than a month and it's not working for you, then that medication either needs to be increased or combined with other treatments to find the right treatment that's going to work for you.
Okay, great. If you have a muscle that seems permanently contracted, will an injection into the muscle make the muscle weak? For example, a hip flexor.
So with regards to the injectables and contracture, for those that are listening and aren't really clear on contracture, contracture is where a muscle that is tight over time becomes shortened. It actually kind of scars down and hardens down in a shorter or flexed position. And so it sounds like the person asking this question has a muscle group that has shortened, and some limb, like the elbow or the knee or the hip, is now permanently in a flexed position and cannot fully extend out. If it is a true contracture where the tendons and ligaments have actually shortened and kind of become hardened in that position, injectables are not going to loosen that. And the treatment for that then becomes an orthopedic surgery to lengthen or extend that muscle group or that tendon or that ligament. However, a lot of things that appear to be contractures on the surface, if we do injections to the muscle groups that are connected to that joint, we can find that it actually isn't a true contracture, it is a shortening of the joint. And a combination of injecting that muscle group and stretching that muscle group and exercising that joint can sometimes increase some of the movement. So it depends upon if it's a true contracture or something that presents like a contracture, and oftentimes the injections can be used almost as a diagnostic tool to find out if that really is a permanent situation for you or not.
Great. If the baclofen pump fails, how much time elapses before the withdrawal symptoms begin?
So the answer to that depends a little bit upon what the dose is of your intrathecal baclofen. But overall, what I can say across the board is the half-life of the baclofen, or the time frame it takes for that medication to start to decrease in your system, is about 1.5 to 2 hours. So what I always tell my patients is there are many things that can result in some of the symptoms that we also see in baclofen withdrawal, such as a sudden increase in your spasticity, or a headache, or a fever. The trick is that for a lot of those different issues, sorry, I got distracted for a moment there. The trick is that many of those symptoms come on slowly over time. So for example, if you were to get an infection, you might have increased spasticity and a fever, but over a number of hours. If the reason that you're having the signs and symptoms of withdrawal is because the pump has failed, that usually comes on all of a sudden, usually in a 1 to 3 hour period of time. You went from being well to suddenly having issues. So to go back to the question, if a patient is having withdrawal symptoms because the pump has failed, usually the onset of time frame for that is anywhere between 1 and 3 hours. It will worsen over the next 6 to 12 hours if left untreated. But we certainly at 6 hours, 12 hours, even 24 hours have treatment options available to us to help reverse the withdrawal symptoms and then treat the patient appropriately.
Will spasticity cause numbness in your legs, and can it also cause a burning sensation in your legs?
Well, the answer to that is yes, but. So spasticity can cause numbness as well as a burning or a neuropathic kind of tingling in your legs, as the person asking the question has posed. But there are also a number of other things that can do that. There is a fine line between pain and numbness related to muscles being tight and underlying neuropathic damage to the nerve rootlets. So that is one that's difficult to answer in this environment, only because each individual needs to have a good full assessment by a rehabilitation specialist or a neurologist or maybe an orthopedic specialist to understand the root cause of your problem. But if you think about what spasticity is, it's the overactivity of the muscles. Is that muscles, constantly and inappropriately contracting. So if you take a normally functioning muscle in your body and contract it really hard, like if you have a good hand and you make a tight fist and you hold it for a long period of time, it becomes numb, it starts to feel swollen, it can become throbbing over time. So it is possible that you can have those symptoms in the lower extremities as a result of spasticity, but it's also just as possible that they can be coming from a number of other issues. So it's very important to make sure that your healthcare provider is fully assessing you to kind of weed out the difference between the two.
Okay, the next question is, the baclofen pump looks big. Is it uncomfortable?
Well, I can only go by what my patients tell me because I do not myself have a baclofen pump. And you're right, it does look big. I'm a big believer in showing people a pump before I talk to them about having it implanted. And for some people, it's very concerning when they see the size of it. For those of you that haven't seen a baclofen pump, it's about the size of a hockey puck or a can of tuna. So it's relatively large, but it certainly will fit. I have patients as young as 6 or 8 years old that it's fit in. I have patients in their 90s that it's fit in. The device is a metal device, but what I've heard from all of my patients, because I do ask every single one about this, is most of them tell me when they first get it implanted, they know that it's there. It seems a little odd when they bend or twist, but it's not painful to them when it's in there. And somewhere between 1 and 3 months after implant, my patients tell me that they stop noticing that the device is there unless they were to have something impact the pump itself. But in that case, when there's an impact to the pump itself, they're playing, they're roughhousing, they've got a belt pushing against it very hard, something along that line. They tell me it's the same as having pressure against a bony prominence, like your elbow or your knee or your hip. So speaking only from my patients' experiences and not personal experiences, I would say that having the pump in does not hurt, but it does take some getting used to.
Okay, great. If you have weakness on the right side from a stroke, could the baclofen pump help in multiple areas, for example, limbs on the right side?
Oh, great question. A point that we didn't have in the slide deck that I'd really like to bring up is intrathecal baclofen therapy is very different than oral baclofen therapy. If you remember back to the slide deck, oral baclofen gets absorbed systemically, which means it goes through your entire body. So that side effect profile, which includes weakness, can happen to any part of your body. When you're receiving intrathecal baclofen therapy, it only works at the site of action, which is in the spinal column, and as an inhibitory neurotransmitter, the baclofen only affects the misfiring muscles, but it can affect any of the misfiring muscles. So what that means is that if you have quote-unquote good limbs, if you have parts of your body that are not affected by spasticity, they are not going to become weaker with intrathecal baclofen therapy. But any of your muscle groups that are affected by spasticity can be improved with intrathecal baclofen therapy. So it can work in your leg, it can work in your arm, it can work in your trunk, it can work in any of the muscle groups that are affected. So for the question, if you have a stroke and it's affecting one side, but it's affecting both your arm and your leg, the treatment can absolutely help both areas, the arm and the leg. Great.
This patient has a question. It seems that ITB therapy would be a better option prior to performing orthopedic surgery. Is that true, and could you elaborate?
Well, I will tell you, whoever asked that question, I am a little biased because I'm a rehabilitation specialist and not a surgeon. But I would say that speaking globally, orthopedic surgery is a great treatment option for improving the length and positioning of muscles, tendons, ligaments, and joints themselves. However, if you have not treated the underlying problem, which is spasticity, that surgery over time will fail because the muscles will continue to tighten and shorten over time. So from my perspective, you need to adequately treat the spasticity, be it with orals, injectables, exercise, or intrathecal baclofen therapy, in combination with the orthopedic surgeries to get the optimal effect and to maintain and achieve as much function and independence as possible.
Great. Is there a minimal amount of baclofen that can be supplied through a pump, which wouldn't interfere with a spastic individual's need to utilize spasticity extension to remain upright?
Okay, so what that sounds like the question is, you know, do you have to need a certain amount of medication to have an intrathecal baclofen pump? That's how I read that question. So hopefully that's what you were asking. Basically, there is a standard dose that we give during that test dose that we mentioned, where we inject a little test dose in the spine to see if intrathecal baclofen therapy is right for you. And most commonly, when we start a pump, we start it at either that same dose or twice that dose for patients. However, if you're working with a provider that's experienced with ITB therapy, they will tell you that we can adjust that dose down, and in many patients, use a smaller dose than the test dose, or even dilute out the medication and use even smaller doses if that's what the patient requires. So I have a broad range of patients. I'm going to just use myself as an example here. I have had patients require as high a dose as over 1,300 micrograms a day of medication, and that's a very high dose. But I've also had a patient that had very little underlying strength, and most of their strength came from spasticity, so they needed to take the edge off their spasticity but leave just enough that they could still do some certain functional tasks. And when we first implanted her, we implanted her at 50 micrograms a day. That was too much. Over time, we lowered it down to 24. That was still too much. And we ended up getting that patient down to 14 micrograms a day, which is the tiniest dose I've ever given. And she did very well. And if we lowered it below that, she was too tight. But if not, when we got it back to 14, she did great. So to circle back to the question, you need to speak directly to your provider about your unique situation. But overall, the right dose for any individual is the dose that works for them. And so there is no limit to the amount that you need on the low or the high end, as long as you have a provider that's comfortable with the different adjustments that need to be done to kind of play around with the dose till we find the right one just for you.
What type of provider can give us this treatment is the next question.
Great. So there are different providers all over the country and actually internationally that work with intrathecal baclofen therapy. As far as the intrathecal baclofen therapy goes, the best way to find a provider near you, and Laura, feel free to jump in if you have a better suggestion, is to go to www.spasticity.com, find a physician, and in there you can pinpoint their location by state and zip code and find different providers near you. There are all different disciplines that work with these devices. So there are physical medicine and rehabilitation specialists, which is the specialty I'm in, that work with this treatment. There are orthopedic specialists that work with this treatment. There are neurologists that work with this treatment, and there are neurosurgeons that work with this treatment. I probably missed some group, and if any of you are listening in, I apologize if I missed you. So what is best to find a provider near you is to speak to the people that are currently treating you for your underlying diagnosis, such as brain injury or multiple sclerosis, and see if they're familiar with anybody in the area, or alternatively to go to the Medtronic website or the spasticity.com website that I just mentioned and look in your area and see which type of providers near you are trained and specializing in these treatments.
Great. The next question is, after the pump implant, is there a dramatic loosening of the muscles to the point that it requires a lot of rehabilitation work to walk if legs are affected?
Well, again, and I don't mean to sound like I'm not addressing a question directly, but again, it does really depend upon each individual situation. Some patients are extremely tight, and some patients are somewhat tight. Some patients have a lot of underlying strength. Some patients' only strength comes from their spastic muscles. So it is a very individualized answer. However, I would say that the pump is highly adjustable. Intrathecal backfin therapy can be turned up, it can be turned down, and it can give you different doses at different times of day. The optimal combination of treatments after you get a pump is to have frequent adjustments to find the right dose for you, combined with appropriate therapies. So if it's the lower extremities, physical therapy; if it's the upper extremities, occupational therapy. Speech therapy may be appropriate in some cases, to make sure that you are optimizing your outcomes, because you need to have goals. You need to have functional goals, comfort goals, care and caregiving, personal hygiene, dressing, bathing type goals in order to know that you're improving treatment. So it sounds like the question was directed towards walking, and if you think about it, as a result of whatever injury or illness you have, your spasticity has changed the way you function. If you end up being implanted with intrathecal backfin therapy, you will have a sudden change. Like once the medication is running, you will now be different in how the communication in your muscles goes. So to retrain those muscle groups and how to move optimally as your provider is adjusting your dose, therapy is a very necessary treatment, and I would encourage those undergoing intrathecal backfin therapy to work closely with physical and occupational therapists so they can optimize their treatment and get the best outcomes possible.
Great. Is the testing dose performed in an office setting or a hospital typically?
The testing dose can be provided in a number of different areas. I have seen everything from bedside in the clinic to an infusion room at a hospital to a surgical suite to an inpatient bed, a radiology suite. It all depends upon how your providers have things set up and what geographical location you're in for what services are available near you. I think ultimately the location of the treatment isn't as important as making certain that whoever's doing the injection is well trained in performing lumbar punctures to make sure that you safely get the medication into the spinal fluid and have a plan for how closely you're going to be monitored for the next 4 to 8 hours afterwards to see what your response to the treatment is, to make sure that you've gotten an adequate test of the medication before you decide to proceed to surgery.
Great. We have a patient here that had a stroke 4 years ago and has spasticity in their left fingers, and they've been getting Botox injections for a year, but they haven't had any relief, and they're losing hope a little bit. Is there anything else that would be worth looking into?
Well, absolutely. Injections are a great treatment for a focal area, and so it sounds, with the information we have, like this is pretty much an issue regarding their hand and their fingers, and so it may be a matter of trying a different one of the toxins, because there are 3 different ones on the market today that are approved for use in the upper extremity. It may be a matter of using different doses or different dilutions. I would emphasize the importance of stretching and exercising those joints, doing some creative rehabilitation therapy with an occupational therapist, maybe including electrical stimulation, dynamic stretch, maybe ultrasound or massage to the area. Adding one of the oral medications that we talked about could be helpful. Perhaps one of the ones that works directly on the muscles, like a dantrium, or something that works on the central system, like a tizanidine. So there are a lot of treatment options for this patient beyond just putting the injections in. So perhaps combining the treatments with these other therapies, or if those things have already been tried, speaking with an orthopedic surgeon to see what might be appropriate next steps to look at those muscles and tendons to see if any of those have shortened over time and need to have some surgical intervention to stretch them might be appropriate.
Okay. If spasticity affects the hands and feet, where would the pump be inserted?
There are two incision sites when you get an intrathecal Baclofen pump. The device itself tends to go in the abdomen, kind of halfway between the belly button and the hip. So the device itself, no matter where your spasticity is, will be placed under the skin in your abdomen. The catheter, which is the part of the device that delivers the medication to the spinal fluid, will enter the lower spine in almost all situations and then be threaded up inside the spinal column, so in between the bones, to the right level for you. The literature tells us that somewhere in the lower thoracic spine is the appropriate placement of the catheter tip. I will tell you that as long as you've gotten it into the spine, you will get good leg effect. And each individual provider kind of has a different opinion on the proper height. And so the catheter tip might go as high as the cervical spine or as low as the lumbar spine. But I would say for this question that's come in, if they're primarily trying to treat the lower extremities, I would stick with what the literature has said of the mid-thoracic spine. Somewhere around the T10 level would be appropriate for this patient.
Okay. How is the medication put into the pump?
So the device itself is located under the skin and fat, and in some occasions, for patient safety, it might also be put underneath the muscle. The medication is housed inside of the pump device itself. So in order to refill the pump, it does involve a very simple office procedure where we do a single needle poke through the skin directly into the center of the device. It has a little port in it that we can access. My patients tell me that it hurts less than getting their blood drawn, and in most occasions, with the average dosing of the pump, this will need to be done about every 4 to 6 months. Even though this wasn't asked, I just want to emphasize here that to adjust the dose of the pump is not painful or traumatic at all. To adjust the dose of the pump, you simply have to go into your provider's office, and we have a little handheld device, looks kind of like a computer mouse. We hold it right over your stomach, over the pump, and we can simply communicate through the skin, telling the dose to be changed up or down as is appropriate for you.
Okay, great. I think we just have time for a few more questions, so we'll do 2 more. I read that electronic devices like cell phones can interfere with the pump. Is this true?
Wow, that's a really important one, especially in today's society. The pump is extremely safe. It is designed by engineers that understand electrical interference, computers, cell phones, everything that's going to be around us in real life, as well as in a medical setting with pacemakers, electric wheelchairs, sequential compression devices, breathing machines. So the pump does very well and runs very well regardless of other electrical interference from everyday household and medical devices. What occasionally happens is when you're working with the programmer communicating with the pump, some of those other devices might make the communication a little complicated, and so we simply turn them off while we're trying to update or reprogram the pump. But the device itself does very well around other electrical devices, and you can safely use all of your household devices such as a phone or a microwave or your electric wheelchair without any concerns for affecting the function of your pump.
Okay, great. And then the last question, can you lose motor function eventually when you have spasticity?
Wow, that's a hard one to end with, Laura. So for whoever asked that question, you know, so there's spasticity in and of itself is the muscles contracting more severely than you want and not in the pattern that you want. And so spasticity is not a progressive disease. However, spasticity occurs because of other injuries. So the injuries we've been talking about today are traumatic brain injury, spinal cord injury, stroke, multiple sclerosis, and cerebral palsy. Now, multiple sclerosis, for example, can be a progressive disease. And so over time, the disease itself can cause a loss of function. The spasticity itself isn't going to progress, but as other medical problems occur, they may result in increased spasticity. And so it's very important to continue to treat spasticity as a lifelong treatment so that you can optimize your function and comfort and remain as independent as possible for as long as possible by having the most functional body you can have.
Okay, thanks to everyone for joining the spasticity webinar tonight, and thank you, Dr. Nelson, for all the great information and for your great answers to the questions. I'm going to flip through some safety information at the end of this webinar here, but we are finished up for tonight, so feel free to stay on to view the safety slides. Otherwise, the webinar is complete. Thank you.
Thank you, Laura.
For those of you that have remained on too, we will be sending out a copy of the presentation. There were a few questions on that. Thanks again for attending. Have a great night.
Thank you.
The organizer has ended the session, and this call will be disconnected. Goodbye.